these truths to be self-evident.
That all men are created equal.
As a member of Congress, I get to have a lot of really interesting people in the office, experts on what they're talking about.
This is the podcast
For insights into the issues.
China, bioterrorism, Medicare for all, in-depth discussions.
Breaking it down into simple terms. We hold
these truths.
We hold these truths.
with Dan Crenshaw.
The Eagle has landed.
Welcome back, everybody. Today we're joined by one of the leading experts in psychedelic medicine. And you've seen me talk about this issue before. But the reason I'm so invested in it is because of how it can help servicemen, veterans, but so many more than that, law enforcement, trauma victims, you name it. It's saved personal friends of mine, this therapy. And I've heard from a variety of veterans since then, since I first was introduced to it years ago, about how amazing it is. We've had a huge win recently with our legislation being signed into law in last year's military funding package, which is called the NDAA. And there's one more step to take, which is getting it actually funded in the appropriations process. We won't bore everybody today with a civics lesson on how that all works. So let's just talk about our guest today, Nolan Williams. He's associate professor of neurology and psychiatry at Stanford University, one of the leading researchers on how psychedelics can impact the human brain. And he just did this really great study, and I want to talk about the really great study. Nolan, thanks for being on.
Yeah, thanks for having me. Yeah,
So we sat next to each other at the Vet Scala in Coronado a couple months ago, and we were both speaking, and you hadn't actually released the data yet. You were telling me about it at the time. So let's just do an overview. What was this study about? Why is it so significant? I'm certainly excited about it.
Yeah, definitely. So, it was a unique study in the sense that, as you know, there were a number of veterans that had already gone down to Mexico, to Tijuana, to take Ibogaine as a treatment for, wounds of war, so TBI, PTSD, depression, anxiety. When we kind of signed up to work on this, a few folks had gone through in 2018, and then we ended up constructing a trial around this phenomenon, around folks going down to Mexico to take this and coming back to the US. And so what's really interesting about this, and, those, I guess, listeners who are interested in history will find this particularly interesting. The last time that sailors kind of directed clinical trial decision making like this was scurvy. It was known since the 1490s that citrus fruit was able to prevent this phenomenon of scurvy happening. And then by the 1700s, the Royal Societies didn't think that the solution could be that simple. But there were a number of sailors who had observed that if they had taken citrus fruit, then they didn't have any of the scurvy symptoms. And so Dr. James Lind actually constructed the first ever clinical trial of citrus fruit versus some of these other modern concoctions that obviously didn't work to treat
Interesting.
scurvy. And so this is a similar sort of thing, and that, obviously the results of that study are obvious, and it's a similar sort of thing. Sailors going down, in this case, down to Mexico to take a plant product that they viewed as helpful for treating, a series of symptoms related to war, came back feeling relatively normal, very compelling for us. And so we constructed this entire trial around it. It was the first ever neurobiology of Ibogaine trial. So, doing MRI, so magnetic resonance imaging, so brain scans, EEG, so brainwave tests, clinical scores, neurocognitive testing, like about as deep of a dive as you can get. And what
Yeah.
we found was that before folks left for Mexico and went down, they had, anywhere between mild and severe symptoms across a whole host of domains, whether it be traumatic brain injury, disability, PTSD, depression, anxiety. But when folks came back from Mexico, the vast majority of them had none of those symptoms, none of the depression, PTSD, and anxiety. But even more striking, the disability related to their traumatic brain injury had resolved. And so that's never been observed from a drug before, this ability to reverse traumatic brain injury
Yeah.
disability. And it seems to, and we didn't publish this in that paper, but we're about to write this up. We have 1 year data. It seems to last for a long time. And so now we're working on getting all of those results put together for, for those later stage time points to really show that not only is this a profound effect, but it's one that's profoundly durable.
Yeah. No, they couldn't come at a more perfect time, because this is we were getting this into the final legislation as word was coming out about the study. It might have come out, I think, right before it was signed. So it was extremely helpful. So it was 30 special operators, as I understand it. It's not a clinical trial per se. It is a
Clinical trial. Yeah, I mean, it's a
it is
clinical trial,
is
just
okay.
not one that
I'm
was. What's that?
I just don't know what the definition is. I thought it had to be like double blind and placebos and all that. It's not exactly that, but it's
Yeah, I mean, so it's not a randomized control trial. So there's a whole kind of host of clinical trials that folks can do. This is fits within one of those definitions, but that's
okay.
a broad umbrella. But yeah, you're correct that it's not
Okay.
the next step is to do a randomized control trial.
Okay. Well, that's good to know. I can call it a clinical trial then. Um, and the other thing I want to clarify for people, this was only for Ibogaine. And can we talk about what Ibogaine is and what that experience is like for people who do it?
Yeah, definitely. So Ibogaine is a alkaloid extract of a Central West African shrub called the iboga tree. So it's basically the bark of the root scraped off, and then people extract the various alkaloids. This particular alkaloid has been known since 1899. The French actually, as a Western discoverer of this, figured out that you could use this root bark for anxiety, and
Mm.
works as a stimulant. The Bwiti, which are the Gabonese people that utilize the iboga root bark, have used it for centuries before that. But interestingly, the French got the iboga, were able to isolate ibogaine, and were selling as a medicinal ibogaine in France from 1930 to 1966. And then when the French version of the Controlled Substances Act was put in place in 66, then it was taken off of the market, but it was used by the French for 36 years at low doses. And at low doses, it appears to be a stimulant. At higher doses, it produces this very unique, stereotyped sort of experience that you could call psychedelic, but this isn't a kind of a classic psychedelic. As you have heard, Dan, I think this marches people through what folks call the life review, or the slideshow, where they see emotionally salient earlier life memories, many of which could be traumatic, and they're able to observe them from a third party perspective and kind of recontextualize them within their kind of viewpoint of the world, and seemingly reincorporate that memory into the way they think about that problem. And so there's a film being produced. They've got really interesting animation that'll be out next year, that could kind of really, illustrate this from
Interesting.
veterans' recollections of this. Yeah.
So how is it different than from a classic psychedelic? Is there an easy way to explain to us laymen what
Yeah.
what the
Yeah.
definition
I
of a
mean, I think
psychedelic is and how
on the
this is different?
pharmacology front, a classic psychedelic affects a very specific neurotransmitter receptor called the 5-HT2A receptor as its primary action,
Hmm.
and it's thought to be primarily a serotonin related drug. Ibogaine works across a whole host of systems in the brain, and it can do some of the things that classic psychedelics do, but a lower potency. It does many more different things at the experiential phenomenological level. Classic psychedelics like psilocybin and LSD can produce all sorts of open eye visual distortions and that sort of thing at high doses. And people's experience are widely ranging, right? With Ibogaine, it seems to, for whatever reason, and most people produce this life review, and that's
Huh.
what it does for everybody. And so that's, from my vantage point, pretty useful clinically, right? Because these other drugs, it's kind of, there's a lot of possible things that can happen, but with Ibogaine, it looks like it's like bumper bowling, like it's putting you down this one stereotyped kind of psychological experience that for all the veterans that we worked with, found to be incredibly therapeutic because they were able to go back and look at the war-related trauma and look at, for some folks, earlier life trauma, things that happened to them in their childhood. Um, and, uh, and
What
that's,
does this say about our brain's ability to just actually remember everything we've ever experienced? And I mean, sorry, deeper question, but I'm sure the one that fascinates you as well.
yeah, it's a great question. And it's one that, I think riddles neuroscientists on how this can, how this can do this, right? Some of these memories, as you're pointing out, aren't necessarily memories that are at the, top of the mind of the person that's experiencing it. Some of them they may have forgotten have happened, and they go in and with like really high clarity, they're able to see, this information and not only have a pretty clear recollection of their own thinking at that moment, but seemingly have some level of intuition on the other person's thinking. Now, what that is hard to understand, but that's a very consistent experience, and so it
The
just
other,
goes, yeah, yeah,
you said open eye hallucinations before, which is common with MDMA and psilocybin. Was it open eye hallucinations with Ibogaine, or do they have to close their eyes? I can't remember which one it was. That my friends have told me, but
yeah. They have to close their eyes. They have to close their eyes to recount all of this, and a pretty normal experience for most people when their eyes are open with it, and so that's why, people tend to kind of stay in there from what we've seen is that, people end up staying in that space for the duration of the experience,
in
but
that
yeah,
space, meaning they're having their eyes closed.
yeah, they're having their eyes closed and they're kind of mentally in that life review sort of place, right? Or kind of mental state or however you want to think about it. But, if folks get worried, they can wait, they can kind of open their eyes.
No, it's definitely described to me as an unpleasant experience. And so, explain what's your view of that? How, I mean, I think I've got a select small pool of veterans that I've talked to. You've got a larger pool.
Yeah, I mean, I think, it's, so nobody's taking Ibogaine recreationally, as you're
Yeah, that,
pointing
that
out,
does
right?
not. Yeah, it does not sound like it's a recreation drug at all.
Yeah, it's not a recreational substance. I think it depends on your frame, right? So if your frame is, I have a lot of these traumatic things that have happened to me and I need to go in and kind of like deal with them, it's certainly not pleasant. And for most people are crying during it or they're very upset or whatever. They're having this kind of cathartic experience and that's unpleasant, but the actual ability to release a lot of this stuff at the meta
Yeah,
kind of level ends up being, maybe not in the moment pleasant, but pleasant for people when they come out of it and they've kind of run the gamut. They're able to look at it and they're able to say, you know what, I've kind of let go of a lot of that. And in that way, it's very pleasant, right? In the longer
yeah.
term
Oh, for sure.
standpoint. But in the
That's
short term, you're absolutely right. It's very unpleasant to have to re-experience what ends up being a lot of trauma on kind of on repeat and kind of like very compressed over a short period of time.
no, and the doctors who were there in this particular clinic. I mean, I'm not sure there was other clinics. This is the one you and I are very familiar with.
Yeah.
It's in Baja, Mexico. Are they walking? Are they doing therapy in a sense the entire time, or are they really just checking vital signs, making sure nothing crazy is about to happen?
Yeah, that's it. It's B. Yeah. So what's interesting about this drug is it's not really psychedelic assisted psychotherapy like you think about with MDMA.
Right.
MDMA is an empathogen or entactogen. It really changes your propensity to see things from a certain vantage point, right? It's
Mhm.
like changing the lens of the glasses, so you're seeing everything rose-colored lenses in that metaphor.
Hmm.
With Ibogaine, it's actually like walking. And that's the really amazing part about this is it seems to walk you through these therapeutic like experiences by the drug's own mechanisms, and it doesn't have. There's nothing. It does it whether or not you're primed to know it's going to happen or not. I mean, that's just what the drug seems to do for some unusual reason. It just seems to put people into that place. And so there's not really a therapist required. But as you point
Right.
out, what's important is that the drug has a cardiac arrhythmia risk. And that part is tricky, right? It's this part around, folks going into an abnormal heart rhythm. And so we dealt with that by co-administration of high doses of IV magnesium, which seems like, on the face of it, not a dramatic intervention to prevent something like this, but actually that's the American Heart Association, first treatment if somebody goes into this fatal arrhythmia, right, is high doses of magnesium. And so what it looks like is if you can do that ahead of time, you can actually eliminate or block a lot of the cardiac risk. But we don't know enough about that preventative step, so there's still a lot of cardiac monitoring. To my knowledge, none of the folks that have gone through that program and have received Ibogaine have had an arrhythmia, and there've been as you know, about 1,000 or so that have gone through. And so it looks like it's a pretty safe procedure, but that's what's so important about actually trying to do, and we're in communications with the Food and Drug Administration right now about trying to do this in the US because, uh, you know, the veterans should be able to get access to this,
It
in the
works. I mean, even 83% remissions. So
Yeah.
that's, I mean, well, you've done a lot more clinical trials than I have. You've done one more, and then you've done more than I have. But yeah, is that a pretty high number? Like, what would be considered a success?
Yeah, I mean, the bar for success is really low. There was like a bunch of news yesterday about a clinical trial where they gave veterans with depression ketamine, and there was like a 16% remission, and like that was being
Yeah,
touted across a lot of different news outlets. So the bar for remission, the percentage of the people that receive a treatment and go in to get it, go into to you know experience total elimination of their symptoms is really quite low, and the expectation is low. You're talking about 10 to 20% usually for drugs.
83% is crazy. That's
Nobody's
crazy high.
seen those numbers before. Yep.
What's interesting too is what I've heard anecdotally is when veterans go through this, they no longer want to drink. They're not on any of the prescriptions that they were on before. It seems like a drug addict to go to this and be cured of their addiction in a day. Is that what's your opinion on that? What are you seeing?
Yeah, so we had about 13 of the 30 were met criteria for alcohol use disorder. None of them met criteria for alcohol use disorder after. It looks like that holds for a while, which is great. And as you said, it seems to have this general kind of habit reset. I mean, I think that looks like that's probably what the core mechanism is that it introduces choice where habitual behavior existed before. And so it seems to wipe a lot of habitual behaviors, things that people aren't even really worried about. Like everybody that drank coffee in the morning had, caffeine kind of habit or whatever, which we all super normalize in the US.
Yeah,
All of those folks quit drinking coffee, which is really quite striking, because they didn't intend to do that. It was just like, here's a habit that I do all the time. This is just what I do in the morning. And then they went from that to not doing that anymore. And I think that's one piece of this that's really, from my perspective, really quite striking is just the kind of broad nature of it. Yeah. I mean, people will quit all sorts of things, in addition to having improved cognition.
yeah, it's fascinating, but we have no idea why. Do you have some theories?
There's some theories, right? For the addiction piece, it's a little bit clearer. So it was a study that was run 15 or 20 years ago, published in the Proceedings of the National Academy of Science, where they took mice, they addicted them to alcohol water, which it's very standard. You can get a mouse to effectively become an alcoholic, and then you can, and then you can, and then
Stupid mice.
there you go, there you go, and then you administer Ibogaine, and they'll stop drinking the alcohol as you would expect.
Hmm.
But then what they did is they took another group of mice and they got them addicted to alcohol, and then they drilled these small holes into their skull, and they injected the neurotrophic factor that gets upregulated by Ibogaine into the ventral tegmental area, the dopamine producing area that
Mhm.
produces reinforcement and reward for pleasure behaviors, and they were able to see the same thing, right?
Okay.
And so you can recapitulate the anti-addictive effects, at least in mouse models, by direct injection of this glial-derived neurotrophic factor into the reward system without
Really?
necessarily having to take Ibogaine per se.
Well, that could
But
be quite the discovery, couldn't it?
yeah,
And
yeah,
for
right.
for our country, geez, 100,000 plus people dead of overdoses. Now, I heard, and again, this is all anecdotes, but I guess the problem is you still have to want to be not addicted. It takes away the habit, and for people who don't want to be addicted, who hate that they're addicted, they'll be better. But the reality is you still know what it feels like. And so
Mhm.
I've heard that story too. It works well with veterans who kind of want to get better. But if you just take a random drug addict, sitting on the streets of San Francisco, I mean, they love it. You could unaddict them and they could still relapse. I mean, at that point though, I don't know what to do. It's still an amazing and fairly cheap potential solution to that problem.
Yeah, I mean, I think, I think that there's always two drives when you're talking about addiction. One is, I think everybody at a fundamental level doesn't want to be, addicted to something, but some of the people, as you're pointing out, miss the pleasure um, produced by the behavior, right? And so what ends up happening is, for some people, they'll go in and they have, every intention of quitting, and then they don't need it anymore, and they're where habit, as you're pointing out, where habit was, now choice exists. But the choice becomes exactly how you laid it out, Dan, is this choice of, man, that's really a pleasurable experience. I wanna do it again, right? And I think
Yeah.
that's at a fundamental level the problem. But that may also be a place where, other forms of, therapy, or kind of, for a lot of people with addiction, they'll substitute things, right? You hear about these folks who have an alcohol problem, and they become like an elite runner because they get a runner's high or something like that. And so
Sure.
trying to figure out how to use this drug to introduce choice, and then giving people other options, may be a way of dealing with it. But, if we can get some people who really don't want to be addicted off without anything else, and then others, they can stop, and then we can find ways to get them to some second therapy that can do the rest of the job. That's a lot further along than we are now, right? Where
No,
we're
of
basically
course.
doing, yeah.
Of course. I mean, it blew my mind when I heard. Um, all right. We're at your time. Maybe we can do this again and go into some deeper conversations about neuroplasticity and just, I mean, all of the other potential uses of drugs like this. I think your work is really fascinating, and I appreciate what you've done. It's helped us a lot. I think we're on the verge of helping a lot of people. So it was exciting to meet you at that event, and exciting to continue to follow your work.
Yeah, thanks, man. Yeah, I really appreciate you and all the work you're doing, and the advocacy work you're doing in Congress. And I think having, the courage to stand up and help your your fellow veterans is super important. So, thank you.
I appreciate it. All right, Nolan, we'll let you get back to it. Appreciate your time.
All right, man. Good to see you. Take it easy. Happy to
Good
be
to see you
back on.
too.